for a lumbar. Okay, a lumbar, it is going to be oblique to visualize the zygapophyseal joints in a 45-degree angulation, side closest to the image receptor.
Posterior oblique.
Yeah, posterior oblique. So if it's an LPO, we're looking at the left
Side.
I think I said right before.
Mhm.
Okay, so
Correction.
posterior oblique, left posterior oblique, you're looking at the left side. RPO, you're looking at the right. And then if you're doing anterior oblique,
Side up.
it's the side that's furthest away.
Okay. So that's correct right there.
This is correct, yes.
Mm-hmm.
Oh, I know what I did. Okay, I know what I did. Why I messed up, okay. I got my anteriors and posteriors mixed up. Okay, are we okay here then?
Mm-hmm.
All right. Okay, and to look at the intervertebral foramina, lateral is best demonstrates that. Okay, it's also a good demonstration for the intervertebral spaces. Okay, so to visualize the intervertebral foramen, it's going to be on the lateral.
Same as thoracic.
You're telling thoracic at me again.
But no,
Right
it's-
there, okay.
yeah, yeah, it's the same,
All right,
yeah.
Let's go back to this.
Different obliquity, but same criteria.
Okay.
Yes.
Yes. Okay, any questions?
I have a question.
Yes.
If you're trying to look at the intervertebral space, you said lateral is the best,
Mm-hmm.
right?
Foramina. And then the intervertebral spaces.
Yeah, that's what I.
Yeah, the spaces.
So
I'm not talking about the foramen, I'm talking about the spaces,
Mhm.
the disc spaces.
But lateral's the best.
Lateral's the best.
Is that true for the C-spine too?
The C-spine, we are also doing it on the lateral oblique. Wait,
No.
You just said this.
It doesn't,
Not
you
for
don't have it listed for the, yeah, you don't have it listed.
what?
The disc space.
You don't have it listed exactly.
Yeah.
Yeah.
Wait, so which position is best for the disc space for the C-spine? Is it also lateral?
Oh, for the disc space is the lateral.
Alright, so that's
for the
lateral all
C-spine.
the way
For the C-spine, yes.
For the disc
Because
space.
for the C-spine, we're looking at the zygapophyseal joints, we're looking at the alignment of the body in the intervertebral spaces, because we want to make sure the body are all aligned. And we're also looking at the spaces in between those bodies, so that's for the lateral. Yeah? Does that make sense?
Mm-hmm.
Or did I just confuse you guys more? Does this make sense? Okay. You know what I was tempted to do on this picture?
Put your face in there.
Really?
I
You
was.
should.
I was tempted.
That would be hilarious.
All right, so are we familiar with the anatomical landmarks, the body landmarks? One that I do want you guys to focus on for the lumbar spine is the iliac crest, which is at the level of L4, L5. Okay? The second one here is the as-is, which is at the level of S1, S2. Those are the landmarks that we will be using frequently for the lumbar. Okay, so iliac crest 4, 5, as-is S1, 2. And are we all familiar with the as-is? How many of you guys have seen a lumbar series or have done one? Okay, is part of your series, does that include an L5S1 spot film?
Oh,
We call
yeah.
it a spot film.
Oh, yeah.
It is. Okay, and have you guys been shown various techniques of how to find L5S1? Some of you guys are doing this.
Yes.
Some of you guys are doing this.
Mm-hmm.
Okay, there's also this.
That's the one.
Yeah, you've been seeing this one too?
Yes.
So there's this one too, and there's also this one. Where should the edge of my palm be when you guys are looking for the L5 spine? Right at the crest, okay. So we'll cover that in a bit. There's many ways to find it. The way I learned it was, I think, Ken, you did this right. Yeah, I do this too. Bless you. Bless you. Okay. All right, radiographic positioning for lumbar, scoliosis, series, sacrum, and then the coccyx. Position considerations. Gonadal shielding for males. How about females?
No.
Why not?
Because their ovaries are in
Because it
the
lies right in the
Yeah.
area of interest, okay? And males do not. Lucky us. Okay, PA versus AP. Okay, this is something new that I put on these slides. The reason why we do with PA is because of the alignment of the vertebrae. It opens up a lot better when placed in the PA position. Okay, so an intervertebral spaces matches the beam's divergence if you do it PA. Well, what's the problem with doing it PA?
It's further away.
Further away, so you get OID. So what happens to detail?
Goes down.
We lose a lot of detail. But this is good for opening up the spaces, but also decreases the gonadal dose to the females. Okay, medium to high KEV, your SID should be a minimum 40 inches. Columning to the area of interest. So if you're using, let's just say, a large image receptor, do we need the entire large image receptor to visualize the anatomy?
No.
No, so we should column it to the area of interest, okay, so the spine. Okay, everybody got this?
Mm-hmm.
Okay. Proper positioning for lumbar if you're doing an AP. If you're doing an AP, are you guys having the patients flex their legs, their knees?
Not really.
No? Okay. It is suggested that you do, because when the leg is flat, it actually accentuates the curvature of the back. If you bend their leg or you put a bolster underneath it, it decreases the curvature of the back, opens up the space, and also decreases OID. Okay. When doing a lateral, are you guys using a lead blocker? Okay. Again, that's your option. If you're working with old school technologists, they'll probably use this. New school, they stopped using it because the digital imaging is so good, it doesn't really get washy from that scatter radiation. But it does help reduce scatter radiation from reaching the image receptor. Okay? All right. So let's do the basic views. AP lumbar spine. Again, we can do it PA, but for convenience and practicality, we do it in an AP projection. Legs bent. You want to get your patient on the table and make sure they're lining up with the length of the table. They're not lying crooked, but straight up and down on the table. So before you take a shot, you want to go at the foot and at the head end to make sure that they're properly aligned. The central ray for an AP lumbar. It depends on the size of the image receptor that you use. Who uses a large image receptor? Who uses a smaller image receptor? So you're using small image receptor, okay? So it does depend on the size of your image receptor. If you're using a larger image receptor, okay, it goes lengthwise, columning to an area of 7 by 17 is the general rule, 7 by 17. Centered at the mid-sagittal plane and at the iliac crest. This is for a large image receptor. If you're using a smaller one, you're going to center up just a little bit higher above, at the level of L3, which is 1.5 inches above the crest.
Did you change it to MSP right there? Because on mine it says MCP.
Yeah.
I think I did.
Okay.
Because MCP is mid-coronal.
Coronal plane, yeah.
And MSP. I mean, I've done it last year. You guys get that? So change that to MSP. It even says it right there. Okay, so for large at the crest, for small image receptor, 1.5 inches above the crest. Breathing instructions. Inspiration or expiration?
Expiration.
Hold on expiration. Okay. hold on expiration. How about that one? You guys have a picture of that?
No.
Yeah, okay.
Is it the lateral?
The image is also upside down. I don't even know. It's upside down and
Is it
upside.
lateral?
Huh?
It's a lateral picture, why can't we
I don't know. I think what they were trying to show was the divergence of the beam, how it matches the divergence of the beam this way.
To open the space more.
But this is AP, it's not PA.
Wait.
Because this is their back, so they're lying on their back. Body's anterior, so it should be flipped.
So it's the
Ignore this picture.
We don't have it on the image.
Oh,
Yeah.
okay, this is the wrong picture that they put up there.
Ignore.
Okay. All right. But PA places the vertebral interspaces more parallel. I think they were trying to show that with a lateral picture of that. So, didn't happen. All right, so your criteria for an AP. Open up, so we want the length to be about 17, but you also want it wide enough to include your SI joints.
Mhm.
Okay, so it's got to include the SI joints. Okay, so T11 or T12 to the sacrum should be visualized. Do we have all 5 on here? 5, 4, 3, 2, 1.
Mhm.
T12. Okay, so you want to see all 5 lumbar spine. No rotation. You want to include the SI joints with optimal exposure factors. Exposure is done on expiration. Okay, this one's pretty easy. All right, the oblique. The oblique, 45-degree angulation. We are looking at the zygapophyseal joints and the posterior oblique. Which one?
Posterior, side down.
On the side down. Side down, okay. So 45-degree obliquity, you can either do it again in an anterior oblique or posterior oblique. When you're doing anterior oblique, you are minimizing the amount of exposure to the ovarian area. So 45-degree posterior oblique, you're going to center 1 inch above the iliac crest. The reason why we're doing 1 inch above the iliac crest is they're not using, for obliques, they're generally not using a large image receptor, but a small one. Okay, hands up again. Oblique, are you guys using a large image receptor?
We use the same one all the way through.
Same one all the way through.
Mhm.
And are you centered at the crest every single time?
I think so, yeah.
Okay. So if you are using a smaller one, we're going to go about 1 inch above the crest. If you are just doing a larger image receptor, it would be right at the crest. But what's important here is you want to go 2 inches medial to the upside as is. Yes, Ken?
If we're going posterior oblique,
Mm-hmm.
and what we're looking for is on the bottom,
The side closest.
side closest,
Uh-huh.
why is our CR centered to the side above?
Okay. Here's your spine. I'm sorry. Here's your front. Here's your spine. Okay. I'm going to place them in the RPO position. So when you go like this,
Still on that side.
okay, the spine is over here. So when you roll them up, the spine's going to move this way.
Okay.
So we're going from the as is. The mid-sagittal plane is going to be over here now. See where her belly button is?
Mm-hmm.
So this is the front. So is that her belly button?
Looks like a
I
mole.
think it's a
Is it a mole?
I thought it was a mole.
Oh, okay, well, her mid-sagittal plane is
It's a
over
belly
here
button.
now.
It's gotta be your belly button.
I think it's a belly
Okay,
button.
so when you roll her up to the side, the spine, because
She had
it's
a laser
posterior,
off.
it's gonna roll over, it's gonna go like this.
Uh-huh.
So here's your spine now. Does that make sense, Ken?
Okay.
Yeah, okay. So we're using the as-is as a landmark instead of the mid-sagittal plane from where to find that, where to find the spine. Another trick that techs have shown us is,
Other-
have they shown you the sternocleidomastoidal?
Yes, that's what I was gonna say, yeah.
Sternocleidomastoidal.
Mm-hmm. It lines up with the spine.
Yeah, so when you roll them up on the side like this, have them turn their head, and this muscle right here
Lines up with the spine.
lines up with the spine.
Or the EAM also. Same
Or the,
area.
you see, there's a lot of tricks to this, or the EAM. Or 2 inches medial to the
I like the
abscess.
sternal. It always
Right.
lines up every
Yeah.
time.
So when you oblique them, have them turn to the side of obliquity. You got this muscle that goes down. You line it up to that muscle. Sternocleidomastoideal muscle is what they call it.
Mhm.
Do you guys do that?
That's
at your
what we.
facilities
That's what I
too?
do. Yeah.
We usually do the EAM.
The EAM, okay.
Well, the interns do the
Okay.
EAM.
Yeah. All right.
We just open call.
Just open up to the room. We'll get it eventually.
All right, also done on expiration, okay? Now, they do 45 degrees. This is, do you guys have this?
No.
Okay. I put this here last year. So if we are looking at, because again, the way the curvature of the back is, it may not open up all the zygapophyseal joints from top to bottom. So if we want to focus on the lower part, the upper part of the lumbar spine, it's going to require a greater degree of obliquity. 50 degrees for L1, L2, and then less of a rotation if we're looking at the lower segment of the lumbar spine for L5, S1. Okay, so 50 for upper, 30 for the lower. So in between, mid-lumbar is 45 degrees. You guys see that down here?
Mhm.
Kind of okay? Can you see it? Stand up. 50 degrees for L1, L2. I'll say it to you. 50 degrees for L1, L2. 30 degrees for L5, S1. 30 degrees for L5, S1. You guys need me to repeat that?
Yes.
Okay. 50 degrees for L1, L2. 30 degrees for L5, S1.
Cross out the 45s.
That's for mid.
No, 45 is generally what you're going to do. Yeah, that's your standard practice.
That's for the mid lumbar.
Yeah, this is just supplemental if you want to focus on different parts of the lumbar. Okay?
Mhm.
All right. So L5 to S1 should be demonstrated. You should see the Scotty dogs. The nose points to the side of obliquity or rotation. Now, how do we know if we have proper rotation? Well, the pedicle or the eye should fall right in the middle of the body. Okay? If the eye was closer to the anterior, so if this eye was up here, that means that the patient was under-rotated. If the eye ended up somewhere towards the posterior part of the body, that means that the patient was over-rotated. Okay? So eye towards the anterior is under-rotated, eye towards the posterior part of the body is over-rotated. I think, okay, posterior obliques, side down, okay. So eye closest to the anterior, it's under-rotated towards the back, it's towards the front, under-rotated towards the back, it's over-rotated. I'll tell you later. All right, any questions? You guys know what a Scotty dog is?
No.
Okay. It comes in all different forms. Wood form, cartoon form, stuffed form. Okay. Lateral lumbar. Okay, lateral lumbar. Before you take a picture, your objective is to make sure that the spine is straight. To make sure that the spine is straight, the line between each iliac should be perpendicular to the tabletop or the image receptor. Okay, so that's the first and foremost thing that you need to do when you get them up on the lateral. So when you get them up on the lateral, arms in front of them, legs bent for balance. You might put a bolster underneath them. If they have broad shoulders or wide hips, again, what you want to do is prop this up accordingly so that the spine is straight, which puts the crest from one end of the crest to the other perpendicular with the image receptor. If you can't accomplish that, then an angulation might be required. If you can get it perpendicular, then your central ray is going to be perpendicular. Okay? So the central ray is going to be perpendicular to the long axis of the spine. Central ray is going to be at the crest for larger size image receptors, or 1.5 inches above the crest for smaller image receptors, which takes you at the level of L3. This is also done on expiration. Okay, what does your book say? It doesn't say here, but is it on the mid-coronal plane, MCP?
Where's the book?
Anybody have the book? You guys don't carry your books anymore, huh?
Only for
We bring one.
Tuesdays, they're
Oh.
so heavy.
Okay. Anyways. Did I tell you how many books? Yeah, back in the day, I used to come to school with only slippers. Ever hear that? I used to walk 5 miles in the snow.
Okay, Grandpa.
Okay, back in the day, we had 5 volumes that we had to carry to class every day.
So you have a strong back, huh?
I know.
5 volumes every day.
5 freaking volumes, man. It was crazy. Yeah, so you guys are only learning just a percentage of what we learned everything, and we were sitting in class like, why? Why are we going to do that? No, but you need to know it. Well, are we going to do that? No, but you need to know it. We learned everything.
That's why you're the greatest.
It was bad.
It says mid-coronal plane.
Mid-coronal MCP. Okay, so central ray at the level of the iliac crest and mid-coronal plane. All right. So if you're unable to get the spine straight, you want at least the central ray to match the what do you call it? The
Iliac line.
Inter-iliac line. It has to match. Okay? Okay, good positioning. Discs are going to be open. Bad positioning. See, because here they have a curvature on the back. Line is perpendicular. It opens up the disc, closes up the disc space. Okay. So T12 to distal sacrum should be visualized. Intervertebral spaces should be nice and open. Sacrum 5, 4, 3, 2, 1. T1, we see the spaces. We also see the foramina in between. Okay. What do we say on expiration?
Mm-hmm.
Okay, on expiration. L5S1. So now L5S1. So from the lateral, so you can stay from the lateral, your central ray will be now 1.5 inches below the crest. So at first you're at the crest, now you're going to go about 1.5 inches below the crest, and then approximately 2 inches posterior to the as-is. So once you go 1.5 inches down, you're going to push your patient forward so that you go about 2 inches posteriorly. So now we're trying to make our way towards the backside, posteriorly, towards the sacrum. Because your back, it has that curve to it, your lower back comes out a little bit, and we're trying to find that sacrum put in the middle of that image receptor. All right. So it says here perpendicular, okay, with support. Are you guys using an angulation on your spot films?
Always.
Always. Always, all the time? What's your degree of angulation?
Like 5 degrees.
About 5 degrees, okay. So again, this is also based on body habitus or if they're male or female. So females have larger hips, which is going to cause the hips to dip a little bit more. So you're going to use greater angulation. So your angulation then, if not perpendicular, it's going to be anywhere between 5 to 8 degrees. Okay, it's going to be greater with females. Now, because we're only shooting the L5-S1, all we're asking them to do is just hold their breath, suspend their breath. The whole purpose of holding their breath, even though we're not shooting the abdominal area, is suspending the breath minimizes any type of motion. Okay, so we're going to have them hold their breath just to minimize any motion during the exposure. Okay. And this is where we were talking about this. Okay. So what I used to do is I used to put this right on the crest. So this is how the way we did it. We put it right on the crest. So the imaginary line between here and my thumb joint, where it bisects, is where my central ray is going to be. Is that how you did it? Yours a little bit different? Okay.
Yeah.
The other one was also putting your hand on the crest, forming a C, and your central ray will be right in the middle of the C.
Okay.
The other way is putting your third finger on the crest, okay, spreading your second finger out, and the central ray will be right on your second finger.
That's too hard.
That's how you guys do it. Okay?
There's an intern that does it like that.
Right, so there's
I-
several ways to
I
do
like
it.
to do it just-
I think there's like 7 or 8 ways to do
Yeah.
it. What I did was I just went 1.5 inch down and pushed my patient forward about an inch, inch and a half, and I hit it every time. But you do as they do, and then you come up with your own technique of how to do it. Okay, as long as you can get that L5-S1 in the middle of your image. Okay? All right. So L4, L5, and S1 should be demonstrated with the joint space open. Again, because we're shooting through a very thick, dense mass, we have to be mindful about collimation. So we're not collimating to the size of the image receptor. You're collimating to maybe a 4x4 or a 5x5. Yes, no? 3x3? But it's small, right? It's very small. Because again, thick, dense, a lot of scatter radiation, and it's also by the gonads. So we want to minimize any type of exposure. Okay, you guys do this. AP axial for the L5-S1. Okay, well if you do it, okay, mid-sagittal plane, your angulation is between 30 to 35 degrees. Okay, for males it's about 30 degrees, and females, because they have a greater curve, it's going to be about 35 degrees, centered at the level of the as-is.
This is almost like doing an SI joint, isn't
It's
it?
like doing an SI joint, exactly. Exactly. Okay.
Is this common, or is this just like trauma?
It's whenever the doctor orders it. I mean, if you would know if it was part of your routine.
So we just collimate tighter, like to just get the sacrum area?
You're
Or-
going to include the SI joint.
You are going to include
Yeah.
that. So it is like doing SI.
Yeah, because you need to see the SI joint to know that that's the lateral borders
Gotcha.
of the sacrum. Okay. All right. So on their back, legs up, decrease the curvature of the back, 30 to 35 degrees, greater with females. Okay. Can't shield, but you can shield your male patients. All right. So L5-S1 should be demonstrated with no pelvic rotation. Okay. Scoliosis series. Have you guys done scoliosis series? So basically what we're looking for in the scoliosis series is the relationship between the thoracic and the lumbar spine. Looking for any type of curving deformities. So are you guys doing yours AP or PA? So face this way? Okay. Okay. Well, books suggest that you should be doing it PA. Okay. We're not looking for detail. So although there's OID between the spine and the image receptor, we're not looking for detail. We're looking for alignment, curves. Okay. So they prefer to do it PA because it's less exposure to the breast, okay, and also the gonadal area and the thyroid. Okay. In a PA or AP projection, generally 2 images are done for comparison, one recumbent and the other one in erect. They usually use a larger type of image receptor, and the image receptor should be of approximately 1 to 2 inches. So I'm talking about the lower border of the image receptor. It's going to be about 1 to 2 inches below the iliac crest. And your central root ray will be centered to that image receptor. Done on expiration. Okay, so 2 for comparison, 1 lying down, 1 upright. Bottom of the image receptor, 1 to 2 inches below the iliac crest. Done on expiration. Okay? When you guys do your scoliosis studies, do you do 1 laying down, 1 upright, or you just do 1?
Upright.
Just 1 upright? Okay, so the thoracolumbar spine is going to be demonstrated. You should have visualization of the spine about 1 and 2.5 inches below the crest with optimal exposure factor. So we got 2 images here again, one with just a 14 by 17 and one with a more lengthier image receptor. Okay. Again, we're not too concerned about detail, we just want to see alignment. How about lateral? You guys do lateral? Okay? Yes? Okay. So I'm hearing now there's different policies. All right, so you're placing your patient in a true lateral position. Same criteria where you place the image receptor, the bottom of the image receptor about 1 to 2 inches below the crest, aligning your patient's mid-coronal plane to the image receptor. Also done on expiration. Done on expiration.
14 by 36?
Yeah, talking about a real long one.
Jesus.
They have long receptors.
For Alex?
For Alex. Alex is going to be 2.
I had a chest X-ray over the weekend, and
Did they clip you?
digital, and she had to take 2 because she clipped one side,
Uh-huh.
and even on the one where she had me perfectly centered, they clipped both.